Hi, everyone. For those who don't, many of you who don't know me, my name is Jay Johnston. I'm a physician researcher here in Vancouver, Canada, and current president of the Union North American region. I took over from Lisa Chen in February. Welcome to our third in a series of webinars on the Union North American Region Conference from late February 2025. This is a highly successful conference, but we know that a lot of people weren't able to attend due to travel restrictions for whatever reason. And so we thought we would bring you some of the highlights from that. And this is the third in that series and the last in this series. And this one is on reframing directly observed therapy, which is near and dear to my heart. And I really found that this was an incredible symposium that really kind of reframed a staid topic, something that's considered a little bit old, but this really breathed new life into this whole topic and really changed my ideas on how we can approach this topic. So it's my pleasure to introduce the two co-chairs. But before I do that, I just wanted to highlight that the North American region will be returning to the U.S. next year to the East Coast, to Philadelphia. Please mark your calendars. February 24th to 28th in Philadelphia is when the conference will be, and it'd be great to see everyone there, because many of you were unable to attend this year. So it's my pleasure to introduce Dr. Kevin Schwartzman and Jane Carter. Dr. Kevin Schwartzman is professor of medicine at McGill University and associate chair of research there, and former Union North American Region president as well. Dr. Jane Carter is a professor emerita at Brown University, also a former president of the Union North American Region and former president of the larger international union. And so I'll hand it over to them to introduce this fantastic topic and symposium.
Thank you, Jay. And it's a good afternoon or good morning, depending where you are. It's wonderful to see so many of you virtually. As Jay said, I'm Kevin Schwartzman. I'm a pulmonary physician based at McGill, and I'm also the associate chair for research in the Department of Medicine. And I'm going to give I'm going to do a few comments to introduce this session. I'm going to basically focus on a clinical vignette to get us thinking about what some of the issues are around directly observed treatment. And a lot of credit goes to Jane and to our other panelists for helping me at least think through some of these issues. So I've held grant funding from the CIHR and the Gates Foundation. I don't think I have any conflicts of interest with respect to this particular presentation. So the vignette I'm sharing is a patient of mine. At the time that I first met a old Quebec-born gentleman with a smoking history who was actually seen at another hospital for sort of atypical chest pain and anxiety, essentially, an anxiety attack. But in fact, to their credit, the radiologist at the time noticed a fairly subtle abnormality, which I'm pointing to here. He was actually referred to our rapid investigation clinic as an individual with suspected lung cancer, but on needle biopsy, this lesion, which we see better on the CT scan with the arrows, was actually found to consist of necrotizing granulomas. At that point, he was referred for sputum induction for AFB smears and TB cultures. He was smear negative but culture positive for Mycobacterium tuberculosis. So a little bit more about this gentleman. He is what we call in Quebec, Québécois de souche, meaning that his ancestors came over from France in the 1600s, essentially, and their descendants have lived here ever since. He works in human resources rather for a major government agency, lives in a suburb of Montreal with his partner and daughter, and is in frequent contact with parents in their 70s. All these other contacts are healthy. On reflection, he realized that he had been having some persistent cough, which he hadn't really paid too much attention to, perhaps partly because he was a smoker, as well as some fatigue. So again, obviously nobody's going to be asked to answer these questions out loud, but some points for reflection are given what we understand about this gentleman so far, would it be a recommendation that he receive treatment under direct observation? And if so, or if not, why? And what either published evidence and or particular elements of his personal situation, his background, and so forth led you to make that particular judgment or recommendation? And of course, we'll be coming back to all these points during our speaker presentations and discussion. Um, might there be additional or alternative information about him or the context in which he lives that would lead you to change your recommendation regarding DOT? And if you do recommend it, how, from a logistical standpoint, would you suggest that this be done for somebody who's a busy professional who lives and works in a context where, first of all, TB is virtually unknown? I mean, he was completely taken aback when he learned of this diagnosis. Of course, it was ultimately better than having a lung cancer, but really something he'd never thought about or considered in any fashion, and also something that is potentially highly stigmatized. And continuing on that point, what if, when offered treatment under direct observation, if that were in fact done, what would you do if he said, no, thank you, I'd like to take my pills under my own responsibility? So just to close and to set the stage for what follows, um, the US CDC guidelines actually recommend directly observed treatment for all individuals with TB disease. In Canada, the recommended approach is somewhat different. Our TB standards, which serve as our guidelines, indicate that people with risk factors for non-adherence, those with significant comorbidities, and those with drug-resistant TB disease should be considered for directly observed treatment. It's recommended that all jurisdictions have that capacity. In other words, they should be able to deliver daily in-person supportive care for people with TB disease, which should be titrated to the needs and situation of the person and might include directly observed therapy. And indeed, as a consequence, the use of DOT varies quite a bit according to geography, setting, and clinical context. And in fact, in Montreal, which is our second largest city in Canada, the clinical program to which I'm attached, as well as our Montreal Public Health programs, do not routinely use directly observed treatment. It's used in specific circumstances. And I would venture that we have at this point, no clear evidence that clinical outcomes differ systematically between our two countries, despite differing practices. Although, to be fair, outcome data are not necessarily reported in the exact same ways in the two countries. Our next speaker is Nicole Skaggs. Nicole is a TB survivor from Seattle, Washington, born in LA, California. She was treated for active pulmonary TB in Seattle, King County in 2022 to 23. She's a member of We Are TB and a volunteer patient advocate for the Washington State Department of Health. And also, I can say from personal experience, is a brilliant speaker and a great deal of insight into what it is to be a person dealing with TB. Over to you, Nicole.
Hello, good morning, good afternoon to everyone. So I am honored to open up this talk with telling you a little bit about my TB experience and my experience with DOT. So as Kevin mentioned, US born in Los Angeles and raised, also US infected. I was actually part of the Microsoft 2020 outbreak cluster. And I had never known anyone in person with TB. My only reference points were really, history books and media. So tuberculosis was not exactly on my life bingo card. It was pretty surprising. So my first impressions really were what I got from my primary care and subsequently from the public health outreach worker. Um, my doctor, my primary care said it was a mandated report to public health. That verbiage was a little shocking. And even more shocking was hearing that I would be directly observed for every medication I took every single day. I didn't have a reference point for this. The only thing I could liken it to was like someone on parole, and they still don't have someone come see you every single day. So my first reaction really was, great, my tuberculosis kind of comes with a side of government surveillance. But I'm happy to report that my first impression wasn't actually my experience. I was isolated at home for 4 months, and I had a really amazing DOT worker named George. And George was basically the gold standard for what I think DOT folks really should model. He was kind. We would have lovely conversations about pop culture, life, everything. And he even played fetch with my dog when I was taking my pills. 4 months of isolation was terribly difficult for me. It was a pretty dark time. I had just gotten married right before I got diagnosed, so I missed my honeymoon. There's not a lot of reasons to get out of my PJs except for, having some nice conversations with George. My dog actually loved George so much that the few days George took off and somebody covered for him, my dog would march down the stairs, see it wasn't George, huff puff and throw a tantrum back up the stairs because it was not George. This led to us calling anyone who covered for George not George in our home. He was very much beloved. But more than just being a great person, he did quite a bit for my side effect and mental health support. Every few days, I would come to George and say, okay, this sounds crazy, but I'm experiencing this weird thing. Or, this might sound really weird. And he would every single time tell me, you know what? I have lots of people that have told me that it's going to be okay, don't worry. But I would tell your doctor next time you see them. And then at times I would come up with some that were a little bit less common. Like I had severe stress intolerance through medication. And he would say, it's not as common, but I've heard it before. And, you might want to actually reach out right away to your doctor, let them know you're experiencing that. So George really normalized my side effects that sounded completely bonkers to me, and made me feel a lot less crazy. And he also helped me prioritize what was urgent, very urgent, just mention it to your doctor. Um, However, after 4 months, 4 very long months, I was finally released from isolation. And George, being the great DOT worker that he was, still couldn't be the same when I was out of isolation. In the US, FMLA job protections are only 3 months. My isolation was 4. So you can imagine there might be a little bit of difficulty coming back to the workplace. I worked for a national property management firm as a luxury apartment manager. And the first day I was told, well, it's a good thing you showed back up because if you showed up next week, you wouldn't have a job. The wheels were already in motion to terminate you. At this point, I had to put in a reasonable accommodation, to work through my stress intolerance and manage that, but B, to accommodate my DOT, to allow a couple hours in the afternoon for my DOT worker to come by, watch me take my meds. But as an apartment manager, the work impact of this is that's a couple of hours that I wasn't available to book apartment tours. And that was absolutely weaponized against me. I was told that that was problematic. I was told that the public health car in front of the building wasn't a good look. And so it definitely had a negative impact to an already kind of stressful work environment. However, fortunately, I was graduated to VDOT shortly thereafter. And when I was treated in King County, the metric for video DOT was culture conversion. I know that varies greatly in different jurisdictions, but for me, it wasn't really until I had video DOT as an option that I truly felt freedom. And video DOT for me personally felt like a really good balance of sort of ticking the box of the adherence and pill count needs of public health, while also just giving patient freedom. Once I could do video DOT, I could travel. Being in my home for 4 months, the first thing I wanted to do was go to Disney World, and I did. I'm sure my video DOT worker had a lot of fun watching me, take pills with fireworks in the background. I went to a work conference that I needed to go to. I had missed my honeymoon, so I went on my 1 year anniversary. We went to Europe and redid that honeymoon. At one point, I actually took my pills on a plane, and my service was a little spotty. So it wasn't until they got to the safety briefing where you overheard the exits are here, here, and here while I'm taking my pills. But it truly allowed me a lot of freedom. Most importantly and most impactfully, though, 45 days after I was released from isolation, my mom was diagnosed with terminal cancer and given 3 months to live. And at the time, she had retired in Peru. And so video DOT allowed me to go to Peru, place her in palliative care, and a few months later, it also allowed me to kind of say those final goodbyes. But video DOT did do a lot for me. Having that sort of check-in was very critical for me because when I returned from Peru, from placing my mom in palliative care, I came back to that very hostile work environment. Gossip was kind of swirling about, rumors to my staff, to my colleagues that I had formerly trained, to my vendors, saying that I might not show up that first day back, that vendors were told to be prepared to work with someone else. They may never talk to me again. And many folks were just kind of told all kinds of disparaging information about me that I was not going to be in my position for long. Obviously, at this point, 3 months after I had returned from isolation and experienced a lot of that hostility, I realized that I wasn't really going to get to stay in this company and retire from this company as I had thought I would. I had been there for 5 years, glowing reviews, but tuberculosis really changed the game. And so I went home that night and kind of had to have a little crisis game plan moment with my husband. You know, we had to figure out our finances. How was I going to, reconcile this career that I had thrown everything into, but also I had to prioritize my health. And how were we just going to make life work? But if you recall, stress intolerance was one of my major side effects during medication. So trying to figure out your whole life while your work is trying to push you out, a little too stressful for me under TB meds. And so I ended up with pretty severe kind of tachycardia, heart palpitations. My Apple Watch was going crazy. I would get stress rashes, sometimes so bad that they would break open and bleed. And the fatigue was pretty debilitating. And this night, the fatigue was so bad, I actually crashed out on the floor of my living room. So my husband carried me to bed. I didn't have dinner. I didn't take my meds. I didn't do my video DOT. And the next day, I woke up to my nurse case manager calling me and asking me why I didn't take my meds. And she was strict but very kind, and made sure to inform me that if I didn't take all of my meds, if I missed too many doses, I would have to start over again. And she really questioned the work environment I was in, whether it was going to be conducive to completing treatment and how important it was for me to prioritize that TB treatment. So, kind of in collaboration with my wonderful nurse case manager, we determined that it was going to be best for me to go back out on medical leave because the environment wasn't going to be conducive to me completing treatment successfully. And at the time, I was very lucky to also have a long-term disability insurance plan. So she helped me fill out those papers so that my bills could be covered. And about 6 weeks before I finished treatment, I was terminated. But I have to recognize the extreme amount of privilege and resources that I have in sharp contrast to the majority of TB patients. I had health insurance to seek out mental health support during this very difficult time. I had a home to isolate in. I had disability insurance so that it wouldn't be a financially crippling situation. But frankly, I'm best case scenario. Most people don't have those resources when they're undergoing TB treatment, TB care. So that's why I come here to speak on behalf of all those folks that can't speak because of the stigma they experience, because of the financial difficulty they experience. TB is much more than take pills, kill bacteria. It is a whole person impact from mental health to life impact, career, families, literally everything. So for those who do care for treatment or do care for a patient in treatment, I ask that you really consider more than just, the pills that are taken by your patient, but also how do the choices you make affect their entire lives, their mental health, their jobs, their ability to care for their children. And so I would say from my own personal public health department, who I think, again, gold standard, I am the best case scenario. I was very, very fortunate. The one thing I would recommend changing is, really consider that metric for transition to video DOT to balance patient freedom with that in-person DOT during isolation. And in closing, I would say that in-person DOT can be tremendously valuable if it's coming from a place of support during isolation. And video DOT can also be really valuable to balance the public health needs as well as patient freedom. So thank you for taking the time to hear me out, and I will pass it back to Kevin.
Thank you so much, Nicole, and apologies once again. And thank you for your, sharing, obviously very personal and at times painful experiences. I think you've highlighted super nicely the fact that we need to think about treatment support and not just, having a person ingest pills, but uh, supporting them in the context of both their illness, but also all the other elements of their lives with which that illness and ultimately cure intersect. So thank you again for that. And I'll now hand the virtual podium to my co-chair, Dr. Jane Carter, whom, as you've already heard, is Professor Emerita of Medicine at the Alpert School of Medicine in Providence, Rhode Island at Brown University. She's trained as a pulmonary and critical care physician and has over 30 years of TB experience, both in the United States and internationally, notably in Kenya. And as mentioned, she's past president of the International Union Against TB and Lung Disease, i.e. the Union. So over to you, Jane. Yeah, thank you again, Nicole, and over to you, Jane.
Okay, so I'm going to give us a historical perspective on DOT and really try to talk about what's happened over the last 40 years in this space. This is my conflict of interest slide. I don't have any relevant conflicts for this talk, and that's a list of my activities at the present time, however. So if we want to think about the history of DOT, I'm going to take you all the way back to the 1970s. And as you face the screen on the left, that is Annick Roulon, who was the executive director of the International Union Against TB and Lung Disease at the time. And on the right is Carl Stieblo, who was the scientific director. And in 1976, the union had a request from Tanzania following the meeting of the African region of the union. And this request was to assist in the integration of health services coming from a network of charitable organizations that were trying to help the national government of Tanzania come into bring into context a national framework for controlling TB and leprosy in their country. And in fact, over the next decade, Stieblo worked on coming up with some type of general plan. And in 1989, WHO turned to Stieblo for advice. And in 1991, the World Bank funded testing of this strategy in several countries. Well, what was the strategy? And I think you're going to see that it's very familiar to you, but it was at that time called the union model. And although if you obtain the original documents of the union model, there were probably 120 or 130 specific points. They always broke down to these 5 tenets. The first is a government commitment to control the disease. The second is an ability to do case detection and find individuals who were suffering from tuberculosis. The third is the administration of standardized treatment under proper case management conditions. The fourth is establishment of a regular drug supply. And the fifth was establishment and maintenance of a monitoring system for program supervision and evaluation. So I just sort of want you to pause a minute and note that the term DOT actually doesn't really appear here yet. Okay. Well, again, let's think about what was happening at the time of 1976 to the early 1990s. What was happening globally in TB? Well, at this time, HRZE, which is the international acronym for RIPE, the 6-month regimen for drug-susceptible TB, had been demonstrated as being highly effective through the British medical trials as early as 1976. However, the new drug in this regimen was the rifampin, and the cost of rifampin was too high for most countries. Well, remember, Stieblo and the union had been invited into Tanzania because these organizations working in TB control and the Tanzanian national program recognized that their program was quite weak. And so there was this grave concern that if you introduce this new drug of rifampin into a week program, that you would lose it rather quickly to drug resistance. And so the original recommendation was that actually observation support might be of importance while rifampin was in the regimen. Okay, but and then just remember though too that 6 months of rifampin plus supervision was thought then to be wildly cost prohibitive. So in fact, globally, the regimen that was being utilized was an 8-month regimen. And it was our usual RIPE or HRZE for 2 months. And then instead of continuing with rifampin, there was a very inexpensive but very effective drug called thiacetazone that was used in the continuation phase. Okay, so that's the regimen that's being used. Supervision is if you're going to put rifampin into the regimen. Well, what was the next thing that happened to sort of change what was being done globally? Well, on the left of the screen, you see the original recommendations in the Stablo model. And on the right, you actually see the Lancet publication in 1991 that recognized that in patients who have both TB disease and HIV infection, that thiacetazone caused a cutaneous hypersensitivity that we also know as Stevens-Johnson that actually has a very high mortality. And it was really this recognition that pushed countries to move to the 6-month rifampin-containing regimen. So that brings us to the mid-1990s. And in fact, on the left of this screen, we have the publication for the WHO TB program, publishing their new framework for effective TB control. And this was the union model of those 5 tenets that we talked about. Well, Craig Clout was actually the communications officer at WHO at the time, and so was trying to look for an easy way to communicate this framework widely. And what he noticed was in the posters on the right, that if you use Stop TB with the outstretched hand and flipped it upside down on its head, it says DOTS. DOTS stops TB. And so this is actually where the parlance of directly observed therapy came into the usual vocabulary of TB control. It was directly observed therapy short course, recommending this 6-month regimen that includes rifampin, and suddenly directly observed therapy becomes part of the parlance. But this was really part of the communication campaign for WHO. Well, again, you have to think and see what was happening also in other parts of the world at this point in time. Well, this takes us to the 1980s and 1990s in New York City, and to what turns out to be this landmark article in the New England Journal in 1995 from Tom Friedman and Paula Fujiwara. So in the 1980s, there had been staff and clinic reductions in TB throughout New York City. By 1989, less than 50% of patients were completing their TB treatment. And in 1992, there were over 3,800 persons living with TB in New York City, representing a triple over the previous 10 years. And 1 in 5 of those persons had TB that was MDR TB. So this was the article that actually described how the New York City Health Department turned around that epidemic. And they did that in essentially about 2 years. And they ascribed a large part of their success to directly observed therapy. And if you look at the graph on the right, you'll see the bars represent the numbers of patients who are beginning to receive directly observed therapy. Now, I think it's important to note that there was a huge infusion of cash to support the programs at that time. It was almost $4 million over those 2 years, which would translate to almost 40 million in US dollars today. But it was this publication that really pushed the spread and adoption of directly observed therapy in the United States guidelines. Okay. Then for the next decade, what you see is that the terminology and guidance, whether it's through CDC, WHO, or other bodies, really varies. They talk about case management with supervision, directly observed therapy during the intensive phase, directly observed therapy when rifampin is utilized, and there is a whole panoply of publications about how to do directly observed therapy. Can it be given by a healthcare provider? Can it be given by family members? Very interesting. Papers out of Philippines showed that family member DOT was very effective, whereas papers out of Thailand at the same time showed the opposite. Can directly observed therapy be done by a community member or leader, an outreach worker, a volunteer, former patients? Well, we keep moving forward to about 2002, and here we have the WHO's guide to DOTS expansion. DOTS is now moved into the title of the policy, but you see, number one is those first 5 tenets that we saw in the original union model. And if you go into the body of this treatise, you'll actually see that the language in the document calls for a tailored supervisory approach. It says supervised therapy, which may include DOT, and it calls for issues such as any type of supervision should be carried out in a context specific and patient sensitive. It can be done in a variety of manners, of places, by a variety of people. Talks about the fact that patient peer support groups are helpful. And there is really even guidance within this document about which patients might be best served by putting them into programs with intensive support, which would, again, it always talks about including directly observed therapy. The next thing that happens is the development of digital tools for adherence. Following around the time of 2015 up until 2017, WHO and the Stop TB Partnership led with a lot of funding about what type of digital adherence tools might be most useful. And these do go from anywhere from like the short phone messaging services to digital pill boxes, ingestible sensors, video recording, whether it's synchronous or asynchronous, or even recording systems such as 99 Dots that came out of India. And tremendous funding has gone into looking at which of these work and their development. And there was, in fact, a DAT task force created at WHO in 2020 to look at these tools. Now, in the United States, the adoption of DOT has often now led the guidelines to focus on this dose count. And so this is actually the table out of the US guidelines, and you can see the whole range of doses in the 1, 2, 3, 4, 5th, or 6th column. But nowhere does this really talk about what is DOT, how do you interpret it, what is acceptable for dose counts. And so the majority of US programs have really moved to the fact that a dose is counted if it is given under directly observed therapy, and each individual jurisdiction really begins to define what that is. So where are we between 1977 to 2025? Stieblo's model was originally a programmatic approach that really emphasized case management, really around this introduction of a new drug of rifampin. And it was really a tool to avoid drug resistance, not so much ensuring completion of therapy. WHO branded the model as DOTS. Okay. The resurgence of TB in the US drove the development of directly observed therapy programs. but most programs have no specific or publicized standard definition. Most of the treatment guidelines note supportive supervision should include DOT, but further direct instructions are often vague, and they're left to be, and it's only noted that they should be adapted to the situation and the patient. The development of DAT emphasized dose verification and may have caused us to lose a little bit of this concept of the case management being so important. And dose verification is really driven by guidelines outlining specific dose counts. And so that's our historical perspective of where the concept started and where we've arrived in 2025. Thank you. I'll stop sharing and give this back over to you, Kevin.
Thank you so much, Jane, really for setting us on the right path in terms of understanding where we came from, and hopefully will help us understand where we might be going or should be going. I should have said earlier that we will have questions and answers and discussion at the end of this half of the webinar. So if you want to put questions in the chat for Nicole, Jane, or Helen, who will be speaking next, whom I'll introduce in a moment, please do so, and we will get to those before the break. However, we're moving directly to the next presentation now, which is by Professor Helen Stagg. Helen is a tenured professor of infectious disease epidemiology in the Department of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. So it is now 7 p.m. or after 7 p.m. where she is. She began her career in the life sciences, later pivoting into epidemiology. She has an extensive track record in working with industry, national and international policymaking and influencing bodies. Helen has a very long-standing interest in adherence to anti-TB treatment, and she held a Medical Research Council UK fellowship in this area from 2018 to 2024. So again, welcome, Helen. Thank you again for joining us.
Thank you very much, Kevin. So it was really great to be invited to do this presentation in Vancouver a few months ago, and thank you for inviting me again this evening, or not this evening in your time. So I'm going to speak today on adherence and clinical outcomes and what that means for DOT and DATs, the digital adherence technologies. In terms of disclosures, I'm just going to disclose that I was funded by the Medical Research Council and National Institutes of Health Research to look into non-adherence in the tuberculosis space, and our original travel for the conference was paid by NAR. Okay, so in terms of the elements we're going to cover in this presentation, there's 3 key learning objectives that I'd like to set out. The first one is about evaluating the current knowledge on the adherence outcomes relationship. The second on understanding the current evidence of the impact of DATs on outcomes. And then the third is to kind of reevaluate the concept of DOT and DATs as a standalone one-size-fits-all intervention or interventions. So I thought a really good frame for thinking about what we know today on the adherence outcomes relationship would actually be to go to the World Health Organization's target regimen profile for tuberculosis treatment, which was released in 2023. And as many of you probably know, in that target regimen profile, it was the first time that we put in forgiveness of different regimens as a key component of what we're thinking about when we try to design optimal treatments. So the table 2.1 here has been replicated directly from that document. And it's divided into forgiveness of regimen. So that's the ability of the regimen to withstand missed doses of treatment without detriment in terms of how well the regimen performs in terms of treatment outcomes. But it's divided up into thinking about drug-sensitive tuberculosis on the left columns and drug-resistant tuberculosis on the right columns. And at the point this document was formulated, the standard of care was thought to be that patients could miss 10% of their doses of treatment without a particularly detrimental impact for the drug-sensitive regimens, and that what we were trying to target would be a minimum of 15% missable with an optimal threshold of 30%. And then we've got written down here for the drug-resistant regimens, 15, 15, and 30. And that's really in there to kind of complement an existing criteria around ease of adherence that was present in the target regimen profile prior to 2023. So ease of adherence is essentially trying to capture various factors in terms of like the pill burden that somebody is faced with, the likelihood of side effects from that regimen, et cetera, et cetera. And the standard of care for drug-sensitive TB regimens at that point was thought to be that in terms of thinking about taking 90% of your doses or more, we thought that about 31% of patients were doing that, 22% of patients taking 85 to 90% of their doses or to under 90%, et cetera, with 38% of patients taking less than 70% of their doses. And then the minimum in terms of a target for a future regimen is actually set for drug-sensitive TB to the same values, but the optimum is set to having 100% of patients taking at least 90% of their doses. And then again, we've got the corresponding figures here for drug-resistant TB regimens, again with this optimal target of at least 90% of doses being taken for 100% of patients. So that's kind of, I think, a really good crux and summary of kind of what's out there publicly in terms of how we're conceptualizing forgiveness and ease of adherence. I wanted to kind of draw your attention to a few things about this. One, at the time this document was written, there was essentially data in the literature for the 6-month drug-sensitive regimen. There was not data for the 4-month drug-sensitive regimen, and there wasn't really data for any drug-resistant regimens either. So we're kind of slightly imputing what we think, particularly for drug-resistant TB. The other one is kind of the interesting contrast in that table. So we're essentially framing that at least the 6-month regimen is for drug-sensitive TB is exquisitely sensitive to non-adherence, with this idea that if you miss more than 10% of your doses, you're going to potentially increase your likelihood of having a negative outcome from treatment. But we're also saying that 31% of patients take 90% of their doses or more, and then the corresponding 69% of patients don't, which is quite a sizable chunk of people then kind of potentially falling into the realm where we've got issues with forgiveness for the levels of non-adherence that are being displayed. And just to kind of then push us on a little bit into how results from other studies have also allowed us to think about these data. So I wanted to highlight 2 papers in this. One is a preprint from Kevin Schwartzman's group and other colleagues. I put the DOI in it on the slide, and that's thinking about the impact of DATs on health outcomes in TB. So it's a very wide-scoping systematic review, and then I've just also put in a reference to a Lancet paper on a particular study looking at DATs. So this study came out in 2025, but just because it's got one of those really useful Lancet research and context boxes quite early on in the paper, which again frames kind of the literature that's out there at the moment looking at the impact of DATs. So to kind of broadly summarize the results of the piece of work in the top section and that research and context box. So there's actually a substantial amount of variability in terms of the evidence about what DATs are doing. It's variable, it's limited. There's good data out there broadly that DATs can improve adherence. There's less good data that DATs are then going on to improve treatment outcomes. Our best data on the positive impact of DATs is in the space of high-income countries, and particularly for video-observed therapy. And then there's less good data essentially in the low or middle-income context about DATs and then the impact on treatment outcomes. And so there's kind of something interestingly contrasting, I would say, between the 2 slides that I've just shown you and the conclusions that we're reaching. And I just wanted to touch on why we're potentially observing this. So the top 4 points are thinking about the DAT trials and studies that have been done to date, and the bottom 3 points are thinking about the studies of the impact of adherence on outcomes. In the top 4 points, so we've essentially got the fact that we all have a bit of a concern that when we measure adherence using a DAT, we're partly measuring adherence itself and we're partly measuring engagement with the technology. And so effectively, we've got a bunch of measurement error, information bias around our measurement of non-adherence. There's also the issue that in some studies, adherence has already been very, very high in the patient population included in the study, often potentially because we're selecting into studies a very specific population. So people who are willing to enroll in a study, and particularly perhaps people who are willing to enroll in trials, might often be people who aren't kind of struggling with systems and processes already. There's sort of how we're measuring the outcomes in those studies. So the profile of outcomes available, and by that I mean the studies that have shown a greatest impact of DATs on outcomes often have quite a high loss to follow-up rate in the pre-existing population before the DAT is introduced. There's also obviously the issue that we all kind of struggle with in TB in different study contexts around blunt outcome measures. So we can't essentially look at a bacterial measure of disease throughout treatment in the way that you could look at a virological measure of disease with HIV over a treatment window. We're stuck with using kind of end of treatment outcomes a lot of the time. Which often are capturing completion of treatment rather than pure cure. And then if we move on to look at post-treatment outcomes, and they're often very, very rare, or perhaps we lose people from studies and they're difficult to capture. There's also this element of kind of differentiated care. So a lot of the DAT models have been using the DAT to determine who needs some extra support. But that differentiated care isn't necessarily always kind of triggered in the way that the people running the studies have envisaged. So moving then into the studies of kind of adherence and outcomes. Part of the complication with doing these analyses is that there's actually a lot of factors that can cause both problematic issues with trying to adhere perfectly to your treatment and also treatment outcomes. And they fall into a wide array of complex spaces. So you've got psychosocial factors, you've got health systems related factors, you've got more standard demographic and clinical factors that we tend to measure. And this means that we're often not quite capturing everything that we need to capture if we wanted to do an analysis that was controlling properly for confounding. We've also got a different issue with loss to follow up here in the sense that if we include that as part of our composite outcome, but don't then account for the fact that that is essentially often included in the denominator of often included in the calculation of percentage adherence for patients, then you're essentially correlating your outcome and your exposure together. So in some instances, people have not been adjusting the denominator of the period of treatment in which they then calculate what percentage of doses was missed by an individual. So you should be thinking about when did the patient essentially exit the study through loss to follow-up. And then we've also got this concept of how we think about adherence and adherence patterns. So we probably should be thinking about them in terms of quite granular information, which we'll go on to later in the slide deck. So beyond a simplistic percentage threshold, and particularly for older studies that don't necessarily use DATs, but they've used other mechanisms to measure adherence. We don't necessarily have data that are that granular, and so we're not able to look into kind of adherence patterns as much as we might like. I'd like to suggest also that it is possible that some patients are kind of more susceptible to problems arising from their non-adherence. And this fits very much into the kind of concept of stratifying patients and then considering what regimens to give them or what length of treatment to give them that has been discussed before. And I believe there was another kind of repeat seminar from NAR on this. So you're probably all aware of work coming out of groups such as Radosavic's, which has been looking at different kind of phenotypes that we can classify individuals under to then allow the stratification to occur. And that's included things like demographic and clinical characteristics of individuals, so the severity of their disease at baseline, their HIV status, their body mass index, etc. And then also PK related information depending upon the regimen that's being used. So somebody's specific levels of a given drug within that regimen. And I'd like to posit the idea that essentially, if you're in a group that's already kind of at a disadvantage because of various of these characteristics, then if you essentially are struggling a bit more with your adherence during treatments, that might be more of a problem for you than it would be for somebody who's in a risk stratification group where you're kind of more comfortably in the clear in terms of achieving a positive treatment outcome. And just touching on the bit that I promised to revisit from earlier. So you can easily conceptualize that if somebody's missing, let's say, 20% of their doses, they might actually miss those 20% of doses in quite different ways across their treatment course. So you could miss 20% entirely from the end, i.e. you discontinue your treatment early. You could miss 20% from the start, so you're kind of initiating your treatment much later than intended, and then you're not kind of adding those missed doses onto the end. Or you could sporadically miss your doses throughout the treatment course. And that will play out in very, very different ways pharmacokinetically, those kind of 3 different models. Now, in preceding work that's kind of come out of my group, we've actually seen that play out in reality, that patients miss doses of their treatment in very, very different ways. So this was an analysis from a few years ago now, coming off the back of a study between Catherine Fielding and a series of colleagues in China, where it was one of the early DAT trials. And the individuals you see on that slide, which hopefully you can see, it might be slightly small, but basically each row in that lasagna plot is a patient. The patients are stacked with the most adherence at the top and the people with the greatest number of missed doses at the bottom. And they're also kind of color blocked. So in the darkest blue, you've got people who took 80% or more of their doses. And as you progress down through the colors, that's less and less a percentage of doses taken. So the key thing that kind of we noted when we looked at these data for the first time was how sporadic those missed doses are, even amongst people who adhere quite highly. So you've really got missingness kind of all over the place during the treatment course in probably quite an unpredictable way. And then as you move down through the categories of patients, essentially in those lower categories, you've got a much more blocked effect. And that's probably people not coming back to claim their next prescription. I should have said at the start, so on the x-axis, you've got doses moving through time from left to right. This was a regimen that at the time was dosed every other day, which is why there's 90 doses in there. And we more recently looked again at lasagna plots of similar data in a study that I'm undertaking in Tanzania with Stella Mpagama and her team. In this study, we actually generally had a much greater proportion of patients adhering very, very highly to their treatment, but we were still seeing that kind of sporadic effect in terms of missed doses. Also, I should say on both plots, we did see missed doses kind of accumulate more towards the end of treatment than the start. And I kind of want to touch on this topic of whether we can ever predict who's going to go on to become non-adherent. And I'm sort of a bit of a cynic in this space, but I'll provide some detail behind my cynicism. So essentially in work that we've been doing in Tanzania, of which this is an example plot, so it's not from a specific individual, but it's kind of drawn together from different people's experiences, just as an illustration on this page. But from the work we've done in Tanzania, we've very much seen how events during someone's normal life have thrown off their ability to perfectly adhere to their treatment during the treatment course. So in this graph, we've got in the blue line moving from the first dose of treatment down in a backwards S shape, down to dose 168. And we had a circumstance relatively early on in treatment where the patient forgot to take their doses due to poor social support, and then later on they had family commitments that prevented them from coming in for a medication refill. poor social support again, and then a loss of their permanent residence, leading to loss to follow-up. And in this study, which is currently under review, we just tried to build a good enough relationship with the patients that we could essentially show them their DAT-derived data during treatment and say, look, we can see that this particular point in your treatment was difficult for you. Can you just tell us why that might have happened? And we can see that you were struggling less during this other periods to take doses. Can you tell us what was useful and what was supportive during that phase? But yeah, we very much found this idea of kind of not particularly predictable events from their normal life hindering their tuberculosis treatment. And that kind of fitted in with other work that I've been involved in the UK. It was qualitative, and it was talking to people with experience of TB treatments about kind of how, well, really about their experience of adhering to treatment, but very much along the lines of Nicole's story earlier. People were very much narrating how much they were struggling to fit their tuberculosis treatment and their tuberculosis diagnosis into their normal lives. And I think for those of us who've been fortunate enough not to have experienced the devastation that TB diagnosis can cause, we tend to forget that the rest of your life doesn't switch off. You can't just get rid of everything else and jettison it, but you're trying to fit those normal life aspects in, as well as all the burden that we're placing on top in terms of what your TB means to you. So I'd say it's very complicated from what we're seeing from different kind of angles of people's stories as to how their lives are interfacing with their adherence. And then obviously on top of this, we've got the newer regimens for tuberculosis. And as I alluded to earlier, we don't actually have an enormous amount of data at the moment, barely any really, on essentially what's going to happen with those regimens and ease of adherence and the adherence patterns that just normal people are going to display in regular life. But kind of the key areas that I think about when it comes to those new regimens. So we've obviously been pushing for shorter anti-tuberculosis treatments for a long time now. And the hope is that shorter regimens will essentially mean that people are able to adhere to treatment better over the duration of treatment that they then have. We know that some of the drugs included in those shorter regimens essentially have longer half-lives, and the hope is that that will increase forgiveness. And then kind of counterbalancing to that, we need to think about the side effects that people will experience and the impact that that could have on missed doses. And again, very powerfully spoken to by Nicole earlier. And then the increased pill burden and essentially how that relates to whether kind of fixed dose combination pills are able to be used for that regimen or not. And obviously that will change very much by setting and by time. So I kind of like to think about moving away from that one size fits all model, both in terms of how we intervene to support people's adherence, but also in terms of how we think about kind of regimens and partly in that stratification space. So I think, we've had this concept for quite a while that effectiveness of regimens will vary depending on various characteristics to do with a given patient. And then we've essentially thought about this interface between the regimen's forgiveness, what its characteristics mean in terms of ease of adherence. We've also potentially got an angle coming in here, which I was thinking about earlier and in conversation with somebody yesterday, about the individual who's taking the treatment and their kind of perception about how treatment will fit into their life, and thus how easy they would find it to adhere to a specific regimen. And as much as I say, I think non-adherence to treatment isn't very predictable, a very wise colleague of mine said to me yesterday, we think it's not predictable as researchers, but plausibly individuals taking treatment might themselves be able to foresee issues that they're going to have, which would then disrupt their treatment taking. So I think if you bring those different factors together, you've got the potential for a conversation with the individual about regimen choice, around, effectiveness of regimens, how difficult we think the regimen is going to be to adhere to, how forgiving it will be for kind of issues around missed doses, and also kind of linked into that, the healthcare system's perceived need for dose-by-dose monitoring based on the data of ease of adherence and forgiveness. And you could quite powerfully then enable the individual to hopefully have a really good conversation with their healthcare provider around kind of what regimen, what care model might work out best for them. And just to touch again in my penultimate slide on DOT and DATs again, and in that kind of space of re-envisaging them. So in the Karumbi review, Cochrane review around DOT, which is the most recent Cochrane review on the topic, once you essentially adjusted for the amount of time that individuals were engaging with their healthcare provider, either under the DOT model or the self-administered treatment model, they found that the difference in how DOT versus SAP performed in terms of treatment outcomes actually disappeared. And so actually it was DOT enabling better engagement with healthcare providers that was causing DOT to perform better than self-administered therapy. And so if you essentially boost engagement with healthcare providers through self-administered therapy, then that difference disappears. And I think that fits quite nicely into this sort of patient empowerment model and how we're conceptualizing both DOT and DATs and how we could think about them in a model that's kind of much more patient engaged, both from the adherence support angle and the regimen's angle itself. So just to conclude then, I'd say that greater subtlety of our understanding in terms of how we sort of think about adherence and why people are missing doses as there are, means that a one-size-fits-all model for DOT and DAT use is just far less sensible than perhaps this model that we've accidentally drifted into over time. Non-adherence is absolutely a really common thing, and the majority of displayed missed dose patterns are actually a few doses missed sporadically, which very plausibly aren't so very dramatic. But there's also substantial variability globally in terms of how much non-adherence we're seeing and what those missed dose patterns actually look like. And so we've definitely got sort of different, I don't want to say issues because it sounds really judgmental, but different kind of concepts to address in different populations against a backdrop of kind of different regimens being used and different models of DOT and DAT. There is the potential that some patients are more susceptible to non-adherence, as well as some of them displaying more problematic non-adherence patterns than others. And that might not be predictable at the start of treatment, but I would love to know if you did have those good conversations with your patients, whether they can predict sort of the struggles they're going to come up against. And then I would very much conceptualize DOT and DATs as part of the package of elements that patients can kind of choose between. So that idea of essentially, how much support do you need? How much support, or how problematic do we think this regimen is going to be? Is there a side effects issue? How can we provide an intervention that is multifaceted and meets all of your needs? So thank you very much for listening.
Thank you so much, Helen. Really a wonderful review of things we know and things we don't know about the relationship between treatment adherence and or less than optimal adherence and the various forms that takes, and its links to clinical outcomes. What we're going to do now is we're going to take about 10 minutes for questions and answers and discussion before taking a break. So I would invite people to place their questions in the chat, and Jane will moderate the Q&A. And again, thank you so much to Nicole, Jane, and Helen for absolutely outstanding talks and for really paving the way for a wonderful session.
So thank you, Kevin. I've been monitoring the chats and haven't had any questions there yet. So please put any questions that you have there, or you can raise your hand and unmute yourself. Since there's nothing there yet, I was going to ask Helen a question. Do you know, it's really interesting since this is the second time I've actually heard this talk, and I've never really thought about it. Most of the fall off for adherence always seems to be at the end of therapy. Does that change if we change the therapy to be shorter? Or is that just a misconception that we all have, that if we told, if we had in the 4-month regimen, is it going to be the same amount of fall off in that portion? If we had a 2-month regimen, is the fall off always for all diseases at the end? And are we fooling ourselves by just saying shorter and shorter is better and better?
I would say that we're assuming that shorter regimens means essentially we're deleting that period of fall off of missed doses from people's experience almost. And I think that that might well be true. And perhaps Nicole can comment on if you'd been told at the start of your treatment you were facing, say, a 4-month regimen versus a 6-month regimen, would that psychologically have kind of altered the way you perceive that horribly long run of treatment and perhaps altered your missed doses? But just to also say that I think it really depends on what the main driver of missed doses is, and that seems to be so changeable from context to context, from individual to individual. Every individual's experience is different. And in the scenario where we've got side effects derailing somebody from treatment, then that's a very, very different question, isn't it? And it will depend on how that side effects distribution occurs across the treatment course. But I'll let Nicole come in.
I think you hit the nail on the head when you talked about the side effects. For me personally, it was sort of a domino effect of the side effects, sort of making it difficult for me to follow through. But it was the sort of intersection of side effects and life, right? So I think at the beginning of treatment, there's a lot more understanding from work, peers, family of, oh my gosh, this is a crisis type of situation. But I think there is a little bit of a compassion fatigue over time. And so, first few months, you have a lot more understanding from folks, where as time goes by, you don't, and that can snowball. I will share that after I dug into my work experience, I was privy to an email that came about 5 weeks after I was diagnosed from my boss's boss that said, I know I've heard that tuberculosis is very hard to treat, so we'll have to keep her on a very finite timeline. So I would definitely say that it's a very distinct possibility that if I came back 100% in 4 months versus 9, that my experience might have been very different.
And Nicole, I just always am really stunned when you give your presentation about the 4 months of being in isolation. And I in addition wonder if the new community guidelines for isolation had been in effect, how that might have helped you if you were out of isolation much sooner.
100%. I think there is an intersectionality there with, at least in the US, job protection only being 3 months. So, at that point, that to me is sort of the target time frame. If you can get someone out of isolation in 3 months or less, or ideally even more through treatment in 3 months or less, we're close with the 4-month treatment. I would challenge all of the researchers out there to push that 1 more month. And then it really aligns with, sort of protecting the livelihoods of folks who, there are a lot of people that go through treatment and don't ever recover financially or career-wise from what they experience.
And Nicole, one other question for you. Someone asked about, in your jurisdiction, did your employer follow all legal protections?
I do not feel that that was the case. There was a good bit of discrimination and not adhering to the reasonable accommodation that was put in before my return. There was a great bit of othering. My supervisor had said that she had never, in all of her years of supervising, ever had an employee who had a reasonable accommodation. I was the only one. So it was basically a hostile work environment, discrimination for sure. And that's something I'm still kind of working on behind the scenes.
Okay. And Helen, Mary Tunsil asks, has there been research around the timing of doses with DOT versus self-administration? For example, splitting doses versus concomitant administration.
And then the impact on treatment outcomes, do we think?
And oh yes, and they asked about efficacy of treatment outcomes. I don't know if you want to try to comment on that.
I can write a comment on that. I would say briefly, as far as I'm aware, no, because essentially the good timing data that's come along has all been off the back of DATS rather than DOT.
And you know, in much of the world, fixed dose combination stops you from taking apart your pill doses. It's really at least I know in the United States, where we don't have that available. And is there any research from, Nicholas actually brings up an interesting question about, is there any research from the provider case manager perspective regarding the impact of DOT?
In a qualitative sense, I would definitely say yes to that. Yeah, absolutely. I wonder, so whether DOT actually essentially works. We on a slightly different but not unrelated note, so I've been doing a not dissimilar piece of work on that in the UK. And the thing that we've mostly found is that if you're an experienced healthcare provider or case manager, then you often don't want additional framework being placed on you. You feel your instinct with your patients is pretty good. Whereas if you are an experienced case manager, then kind of any additional framework on how to support patients with their adherence and kind of what to look out for is perceived to be a bit more positive. But it'd be interesting to hear from other people in the audience as to what their perspectives of DOT are.
That was in the UK?
Yeah.
Nicole, there's another question. Were you able to enforce your legal protections?
That is actually still ongoing. So being in the US, I did go through EEOC, which was moderately helpful. But I recognize that I'm fortunate to have the resources to work with a private attorney. But it's a very costly and time-consuming process. I finished treatment in September of 2023. We are in 2025, and I don't anticipate all of that to wrap up until next year. So it's a process that not every TB patient has either the literacy or the resources, because it's been tremendously difficult to go through that process. That's still ongoing.
Interesting. I've never thought about the legal ramifications of post-TB disease.
Yeah, I mean, I did feel that I faced a hostile work environment upon return. And I also had reasonable accommodations that weren't necessarily honored. And while those laws exist, what happens if somebody doesn't actually follow them? There's rules and law, and then there's accountability. And holding a company or an individual accountable isn't a short and isn't a cheap process.
And Nicole, there's another question for you about Alice was curious whether you had MDR-TB, and that was why you were in isolation for so long.
Nope, I was active pulmonary TB, 4+ smear positive, so heavy disease burden, heavy cavitation, but drug susceptible active pulmonary TB, just I guess a stubborn bug.
And I do assume that that your treatment was before the new community guidelines, and so people were waiting for maybe culture negativity before
Correct,
letting
the
you
3 sputums.
out of isolation. So I do just want to point people to those guidelines, and I'll stick them in the chat in just a moment, that point out that we've for a long time left people in isolation for too long, and there's just much better guidance now about if people are on effective therapy, letting them out of isolation much sooner. Oh, they were asking if your Department of Health DOT workers were able to help you with your work issues.
They were
Nicole.
extremely supportive. My nurse case manager was the one who facilitated my reasonable accommodation, as well as paperwork for my long-term disability insurance. So 100%. And probably 2 months before I was released from isolation, I was very vocal about the fact that I had a boss that had previous history of being discriminatory towards other disabled folks. So I really did anticipate this to be an issue, and I wasn't wrong.
And I'm going to have one more question that I'll bring forward now. I think this one is interesting from Erica. She notes that typically she only manages 1 to 6 active cases at their jurisdiction, which is smaller. And it's interesting. She says, I have found that we experience more issues with drug resistance earlier in treatment, and this is typically due to medication coverage issues rather than side effects. I think that's an interesting, I never would have thought of that as an adherence issue. I think of that as a program issue. I didn't know if anyone wanted to comment on that, but I just wanted to raise that issue. So,
I will just briefly say, so there's a chap called Professor Rob Horn in the UK who's written, it was actually some UK guidelines that were pandases on the sort of definitions around adherence. And in those definitions, technically adherence would be that the healthcare provider and the patient is supposed to agree how treatment is taken, like an actual discussion between the two, not just the healthcare provider telling the patient exactly this is the one model in which you take your treatment down to the precise minute or hour of the day. And so often then in terms of kind of side effects, that if the healthcare provider agreed that the patient should miss doses of their treatment, then that wouldn't be classed as non-adherence, which is why I tend to say missed doses quite a lot, because it captures various different aspects. And with that missed dose framework, then you've also got the ability to capture essentially programs not being able to provide medication to individuals because of like medication stockouts or some other issues along those lines.
and Nicole, I just wanted to also mention how many people are talking about sending you best wishes after all of this experience. And there is one question from Sammy that he was wondering how you're doing now, particularly in terms of long-term health sequelae.
I would say generally well. I do have some lung fibrosis, but it's mild to moderate, so it's pretty manageable. But I will say, and this is asterisk particularly at all of those in research in the participants, is that I did experience some fertility issues that maybe have been linked to my tuberculosis treatment. I was trying to conceive when I was, before I was diagnosed. I went to a fertility specialist after I completed treatment, and they found both endometriosis and Asherman's, which nowhere in TB research does it say that that's a possibility. But when you research those conditions, it does say they're common in people who have had TB treatment. And so I'm very lucky that I was able to, again, have the resources to go through some procedures and a year of fertility treatments, and I'm currently pregnant. But it was a very long road that TB very likely made much longer.
So congratulations. So that's the most positive note we could end this this part of the session on. Congratulations, Nicole, and we're all wishing and hoping for the best for you. Thank you again to our three outstanding speakers. Really, I think we've all learned so much, and I think the level of interest in the chat is indicative of how engaged our audience has been. So thank you again. Basically, what we're going to do now is we're going to move on with the remainder of the of this plenary session, and we're going to focus particularly on what treatment support could or should look like for people with TB, moving away again from the dose or expanding beyond dose monitoring and thinking more broadly about how we might approach treatment support. For our first talk, we're going to hear about TB versus HIV, differing approaches and understandings of treatment support and supervision from Professor Amrita Daftari. Amrita is an associate professor at the School of Global Health at York University in Toronto, Canada. She researches the social dimensions of TB and TB care, including stigma and inequity, primarily using qualitative approaches. She's an highly experienced qualitative researcher who works along trialists and in allyship with TB-affected communities in South Africa, India, Indonesia, Ukraine, as well as Canada, among other countries, and with global decision makers. She's founder of an highly impactful social science network in TB called Shift TB, which you can find online. So welcome, Amrita. Thank you so much for joining us and looking forward to your talk.
Thanks so much. Thank you so much to everyone for having me here. Thanks to Gal and Lisa and Kevin for that nice introduction. It's a real privilege, and I did want to extend my thanks to those who organized the extension of this NAR session. I'll begin by just acknowledging being on the unceded traditional territories of the Anishinaabe, including the Mississaugas of the Credit, Haudenosaunee, and Huron-Wendat, and to thank those who steward this land. I've edited the title of this talk ever so slightly because I tend to come to TB from, as Kevin mentioned, a social science lens, which means I like to sort of interrogate the things that we take for granted and assume. So here I'd like us to just reflect for a moment on, whether supervision is a form of support or whether we can maybe just challenge ourselves and the assumptions that we come to this with and inquire, are they possibly antithetical? And this type of thinking often ruffles up some feathers in the room, but please know I'm not coming from this from a place of ignorance or sort of traditional critique, but really just with a view to get us to revisit some of the normative ways of thinking and doing in TB and try to imagine if there is another path to help push the needle forward. I have no conflicts, but I am presently working with some groups and stakeholders in TB, and I receive funding from others, which has just trickled down very much in the last few months, but I don't have any conflicts of interest to disclose. In this talk, I will problematize how we approach treatment monitoring and support based on comparative lessons learned from research involving people who've been exposed to other forms of treatment away from TB, such as HIV in particular. And I invite you to sort of reflect on this contrast in care and an experience that they've had as a result of that care, not so much to laud one program and criticize the other, but these are obviously very different diseases, and no doubt a bacillus is much more difficult to treat than a virus, but maybe just to cast a second gaze at what we've become entrenched believing and doing, as I mentioned. Basically, are we inventing a wheel, and do we keep reinventing and refining it while forgetting that we really have to navigate underwater? I started to become aware of these blind spots in TB care myself by talking to people with tuberculosis in South Africa a long, long time ago and until this present day, where a very large number of people with TB also live with HIV and are trying to navigate concurrent treatments and cares for these two infections. And I've literally seen people with these two diseases trying to navigate concurrent treatment and care for their two infections and encountering very different and difficult spaces, literally trying to be, literally being pulled apart in different directions, almost as if they were children caught in the crossfire of parents who had never quite figured out their marriage. And this fragmentation of care ended up being a very ideal opportunity for somebody like me to compare how care is being organized and delivered for people in HIV in that space as compared to in the TB space. Again, not to sort of critique and laud one or the other, but really just to identify some blind spots. And an HIV researcher, for example, could very well do exactly what I did, but learn from TB to sort of support strengthening their own programs. But because I'm obsessed with TB, that's what we're going to talk about today. I'd like to thank at the outset the scores, dozens and if not more people affected by TB and HIV, as well as care providers who over the years have shared their experiences with me, and I will share some of that with you today. The program managers, the implementation scientists and trialists who have worked with me to help translate some of these ideas into interventions, into changes in healthcare practice, and how we think about monitoring, supervising and supporting people with TB. I'll very quickly bring you some recycled data, essentially from studies that have already been published, dating back to 2012 till 2022. But this time I'm going to emphasize the very particular ways in which we attend to TB in contrast to HIV. And again, many of you might be thinking, well, what does kind of research in South Africa or other parts of the world have to do with the work I might be doing in North America? And again, I want you to just kind of not focus on details of country and context, but focus on the comparisons in care that people might be experiencing in TB compared to some other spaces in their lives, in their social lives, and see is there anything that we can gain. During these studies, we have interviewed and held focus groups with close to 200 to 300 participants living with both HIV and affected by different forms of TB, such as drug-susceptible TB and drug-resistant TB. We did not speak to people with latent or TB infection. And across a vast diversity of backgrounds, circumstances, different histories and care, job status, marital status, gender, race, education levels, their accounts really told of a very troubling norm in TB care. Some of these quotes might reverberate for those of you who work with people with TB today, or even have experienced TB yourself. And I'll just read some of these quotes here. XDR TB, no one tells us what's going on with it for a period of 2 years. Is it treatable or not? They're confiscating people at the hospital and not giving information. My son just ran away because they told me about TB in his presence. You need to encourage me, console me, show me that this is not the end of the day, that I'm still going to live. My providers have the tendency of shouting, of being rude. They give you food, but they give it while at the door, and I can feel bad. I just take my medicines with a spoon so that it will be as if I'm drinking it, but then I throw them away. I throw them in the sink. These same participants and similar accounts taken in the same period of time, collected in the same period of time, reveal a very distinct pattern in HIV care. And they are telling of a very different social experience for somebody who is receiving treatment for HIV. And you can imagine how this can shape people's acceptance of their disease and their engagement in whatever care they're being exposed to. Again, this is going to reverberate with some of you who have treated people with HIV or who might be living with HIV or working in HIV programs yourselves. I don't default ARVs. This is my free way. We're told about our viral load, our CD4 count. This really motivates, but I did not know anything about my culture results, my MDR results, my sputum. The TB clinic, no one's taking care of you that much. If you're in a right space where you are, while at the HIV clinic, you're taken care of. There's a difference. It's as if we're paying money. At the TB clinic, I just go and take my tablets. At the HIV clinic, I talk, I say hi, because whatever's bringing that person here, it's the same thing that brings me here. I never dodge ARVs. It's because you take ARVs, they tell us the tablets might do this and this. If you don't take it on time, this is what's happening. If I can dodge, I'll dodge TB. Lots of tablets, they're bitter, they're sour, so many side effects. They should explain. 1, 2, 3, what should you expect? If they can offer us counseling, like with HIV, I'll be able to better understand what I've got, explain it better to my family, and be encouraged to take treatment. So this perspective is especially valuable because these participants are in a very unique position. They're accessing concurrent care from 2 different programs that are steeped in very different care practices. In a sense, the fact that HIV and TB care have not been as well integrated as we would have liked has allowed us to sort of see the different experiences that people experience in these 2 different spaces. These participants also form the perfect case control, right? They had the perfect blend. Many of these individual level characteristics that we tend to assume sort of account for a clinical outcome were canceled out because it's the same participant telling us their story. Regardless of their gender, education, age, and income, they're identical across both sets of experiences, and they can speak from quite an authentic voice. The distinction in their perspective and experiences in these 2 programs has been uncanny. It's also been validated by observations in the region, in the South African region at least. And you might again find that this is common to the settings that you're working in. Here's a visual rendition of what I've observed in dedicated TB and dedicated HIV service delivery spaces over a span of 2009 to 2015 in KwaZulu-Natal. But when I walk into such spaces today, I continue to observe a very similar vibe in the absence of a trial or a program intervention. Now, things might look a little different in the spaces that you work in because you might be working in better resourced places. But think about, again, the relative difference in how we attend to people with TB compared to HIV. What I observed very quickly is that within HIV clinics, there is an excited chaos. There's a conversation, there's milling and moving about of people. There are not just patients in the room, there are counselors, there's kids, there's health workers coming in and out, and people are handsy. They touch one another, they touch patients. Health workers touch patients on their shoulders and their arms, and patients tend to come, you evoke that emotion back to the workers that are looking after them. There's many different rooms. There's doctors and nurses, but then there's other rooms with social workers, dietitian signs, counselor signs. And through my very rough knowledge of Zulu at the time, I could gauge that people were talking about way more things than just their medicines or their health. They're talking about their weight, their kind of the weather, the news, their partners, their kids, money problems, work problems. And whenever a patient needed to be seen, the health worker came and got them. They literally came out and picked them up in a way and got them back to the rooms. The walls were replete with very colorful images showcasing ribbons, smiling faces. For obvious reasons, I don't have these photos with me, but I hope you can imagine if you were to think about an HIV clinic or an HIV NGO or a space that is working with people with HIV looks and feels like. It's welcoming. At the TB clinics, I noted an apparent order. It was full and it was populated, but things were very quiet and sterile. Right? There's social distance between those who are present for justifiable reasons, masks, patients sit quietly in the waiting room. There's very little mingling, very little chit chat. Nurses and doctors remain in their offices or behind desks. They step out, call patients out loud. They don't come and get them. And there's seldom any allied staff or counselors milling around, right? It's a comparatively somber and stern space. Even staff that we've spoken to acknowledge this difference in program cultures. Patients will tell you their problems at home, stuff like that, what affects them in taking TB treatment properly. And sometimes we don't know how to deal with that. We're not equipped to deal with these social problems. HIV providers, they know the social aspects. They know the treatment aspects. They know the side effect profiles. They're very empathetic. They listen when patients ask. We, HIV providers, understand them better. I think that's why they sort of relate with us in a better way, because we don't discriminate. So you start to see what it might feel like to access care within an HIV clinic space versus what it might be to access care in a TB care space. Now, the contrast, again, it's not intended to make those of us who work in TB feel badly or upended or to minimize the very important efforts and the progress that we've achieved. My guess is many of the South African accounts may not exactly resonate with what you're seeing in North America, but again, please consider the difference. Social science scholars have noted this difference in why TB and HIV care are differently organized, that these are distinct infections, distinct etiologies, they have different transmission pathways. They've affected different populations and parts of the world that have been mired with very different political histories, funding, political momentum, etc. And it's exactly for some of these reasons that we might see a bifurcation in how services for HIV have developed over services for TB. But when working with an incurable disease, such as HIV, maybe you just got to work with the patient for a long term, right? And that's why maybe some of the HIV program is a bit more holistic in nature. However, TB is a pretty long-term infection too. And having TB is highly stigmatizing and highly socially unacceptable in many, many settings too. So we have to put in that effort to sort of attend to some of these social challenges associated with the disease in the ways in which we design treatment models and treatment monitoring models. Now, I know this session is about DOT, but in contrasting approaches to care for TB and HIV, I'm compelled to say that DOT is just a symptom of a much, much bigger problem, a much, much bigger blind spot. The ways in which we've organized, standardized, universalized approaches to TB treatment and care and treatment monitoring, so not just limited to DOT, but all of the modern versions with all of the bells and whistles of treatment monitoring, they don't necessarily address the vast majority of barriers to adherence that people with TB need addressed. It's not just DOT, but it's how we think about and design all aspects of TB care. What I loved in Nicole's talk is that she talked about DOT, but what she really was talking about is the touch points that she had with a caring and loving health provider, right? That was really what she valued. The ingestion of drugs, the daily contact, it was the kind of human relationship with the person who might be able to support her in whatever she's going through during treatment that she remembers and values today. So if we were to take a step back, and think about some of the philosophical sort of underpinnings of TB care, the different kind of hierarchy of priorities that we might have created that have enabled us to sort of think about patient-centeredness and equity in principle, but also omit all of those values at convenience. If they come in the way of achieving a biomedical outcome, we might need to kind of question the foundations with which we do TB care, right? In TB, we arrive at every process and step from a position of control, disease containment, distrust, and therefore scientific hegemony, right? That's what our aim is, to get rid of the disease, protect the public, right? And so we focus on the bacteria instead of the person that it's inhabited within. We screen and test without usually explaining or asking. We notify a positive result very publicly. We conduct open contact investigations with generally very little regard to the social and economic ramifications of that act. And we control when and how people take their medicines with this assumption that if they were left to their own accords, they won't take it, right? And this is a very sort of, it's antithetic. It's at odds with people's human rights. It's laden with much ethical dilemma, misaligned with any concepts of people-centeredness in any other disease state. And others have written about it way better than what I'm sharing today. And I know Jonathan's going to get into this a lot more and a lot better. Now, there was a time when HIV treatment guidelines were also, the just say no to drugs approach, ABCs, don't, abstain from sex. It also had a very commandeering authoritarian tone with little patient agency, with little kind of, time and resources allocated to sort of people-centeredness. But if we were to go back to even some of the earliest clinical training books in HIV that were produced by the CDC, the ABCs of AIDS, for example, you'll see that there is a holistic kind of people-centeredness embedded into that language and into that guidance even then. I quote the CDC's first guidelines on HIV care state, when patients know that they've got HIV infection or disease, they may suffer great psychological and sociological stresses through fear of rejection, stigma, disease progression, and the uncertainties associated with future management of HIV. Good clinical management requires that such issues be managed with consistency and professionalism, and counseling can both minimize morbidity and reduce its occurrence. In the 21st century today, we still don't see this guidance, this kind of language embedded at the start of almost any TB guideline. Current approaches to HIV education and treatment, they reject the blind standardization and universalization, right, of HIV care. Of course, there are treatment regimens and, what matters in a treatment regimens and dose frequencies, et cetera. Nobody's arguing against that. But they also embrace the diversity, the sexuality, the choices, the rights of people with HIV, and capitalize on peers to marshal people's engagement in care, right? If you look at the table of contents of this sample HIV service delivery guideline from the WHO, you're not just seeing headings about the drugs and the tests. You're seeing headings about adherence support. You're seeing headings about counseling. You're seeing headings about how to manage key populations affected by HIV, and what are the nuances in care that you need to sort of, embed into service delivery. How to prepare people for ART. We don't prepare anyone for TB treatment. That subheading is entirely missing, or any version of it, in the TB space. By contrast, as mentioned, we're maintaining a real separation of these important aspects related to ethics, rights, values, trust, empowerment in global guidance for TB, right? If you look at even just scan through the pages of the textbooks that we rely on, the standards of care that we rely on for TB and HIV, they're so vastly different. In TB, literally the table of contents is all about the tests and the drugs. Sure, we have these beautiful manuals, and I'm working on one of these manuals myself, on how to do this better. But what everyday doctor is going to read through these manuals, right? They want one book, and it needs to be comprehensive. And it needs to be comprehensive so that ethical care, rights-based care, supportive, holistic care is mainstreamed. It's not an add-on. It's not something that you have to check off if you have the resources. It's mainstreamed. When it comes to patient education and support, this is one of the go-to approaches outside of DOT that supports people with TB in taking their treatment, right? The materials in TB tend to focus on these very clinical aspects of TB risk and treatment under this sort of do or die approach. right? We don't include the types of things that people with TB actually want to learn about or hear or feel pacified with. Talking to survivors in very many parts of the world, including Canada and the US, there's so much more that we can say, right? When will they stop being contagious? Where are those bloody de-isolation guidelines, right? They're all over the map. I've sort of read through dozens of these guidelines across the country, across different states, across Canadian guidelines. I think you'd need 3 PhDs to decipher that guideline. When should people de-isolate? When can I sleep with my partner? When can I kind of, go back to feeding my child? How do I deal with the different side effects? What are the side effects I really have to be worried about? How can I change my refill schedule date? Where can I access financial assistance? What do I do to go back to work or school? These are the things that matter, but we don't talk about this in our support strategies for TB. Over the years, we've seen massive movement, and people-centered approaches are absolutely coming through. If we really think about how we treated TB, 30, 40, 50 years ago compared to today, huge shifts, right? So nobody's denying that. And individual countries are absolutely making headway. There is some great language around adherence support in the national guidelines in South Africa. There is some great language around being mindful of sort of historical colonization and the history of kind of unjust approaches to TB care amongst Indigenous people in Canada. I have not read all of the guidance and supportive approaches to managing people with TB in the US, but I'm guessing that there is a lot in many of the guidelines, so not to bring away from that. But for a moment, go to the same guidelines in HIV in your own kind of jurisdictions and see what's included. In the Canadian space, for example, we have a chapter on happiness in HIV. We have a chapter on how to manage HIV in elderly people and in very young children, right? I mean, so where are we missing the mark? Can we, again, this is not to laud and criticize, but just to see, can we like broaden our approach a little bit more? Can we widen the things that might be mattering to the people with TB in the spaces that we work in, and sort of push the needle forward alongside whatever other technological things that we're sort of, I'll just end with this. I think where there's a lot of work being done in the community. There's been a lot of work with civil society advocacy, the work that I'm sure many of you are already invested in sort of pushing that needle forward and bringing people-centeredness into the TB care space, into the TB treatment monitoring space. People like Nicole, the amazing stories that they've shared with their experiences with DOT, I would never wish to take away from that. But there's something that we might be missing, and there might be a whole other world that we need to sort of open ourselves up to. And maybe it's really about finding the boats and navigating underwater rather than reinventing the same wheels time and time again. So I will end with this, and thank you so much. I look forward to the discussions. Feel free to email me in case you need to sign on. Thank you.
Thank you so much, Amrita. In a brilliant talk with a lot of points for reflection for those of us who've been sort of immersed in the TB world for perhaps too long in some cases. But as before, we'll save the questions for the discussion period at the end. And now it's my great pleasure to introduce our final plenary speaker, Professor Jonathan Stillo. He'll be speaking on DOT, human rights, and ethics. Jonathan is a medical anthropologist and associate professor, just promoted, so congratulations, at Wayne State University. He's researched TB for more than 20 years, with research and advocacy focusing on the social, economic, and political dimensions of the global TB crisis. He's the chair-elect of Stop TB USA, vice chair of TB Europe Coalition, and he's also an emeritus member of the Global TB Community Advisory Board. So thank you again, Jonathan, for joining us this afternoon, and over to you.
Thanks so much for the introduction. So thank you so much. It's so nice to be here with everyone and to follow these amazing presentations. So I'm going to talk about the human rights and ethics of DOT. And one thing I want to say is that now those of us in the US, and well, this has spread globally, are really fighting just to preserve public health and science and things like that. And it can be a little tough to think about how can we reimagine things, how can we make things better. But I really hope that we can do that, and we can think about not just maintaining what we have, which I would argue is inadequate, but also thinking about how we can actually make this better so that it serves everyone. So I have no conflicts to report. And so I'm going to try to do a few things in this presentation. I'm going to discuss DOT from a person-centered and human rights-based approach using original ethnographic data and some other published data. And I'll look at whether DOT is happening in real life as we describe it on paper in the guidelines and how that variation is happening. I'll look at DOT in light of the human right to health, and particularly using the availability, accessibility, acceptability, and quality framework, as well as non-discrimination and privacy and the right to participate in terms of work, in terms of family life and culture and things like that. And what I would argue is that DOT, as it's commonly happening, and we've heard a lot of range of the way that DOT happens already, but the way that most people encounter DOT is not in keeping with human rights, and that we should move beyond this one-size-fits-all approach, which has really dominated TB for quite some time, and instead be moving towards rights-based, person-centered models that allow for differentiated care and treatment support based on people's values and preferences, moving away from the surveillance and really doubling down on the support. So a little bit about me. I've been working on TB for over 20 years now. I stumbled into it as a grad student and found myself unable to leave it. And in that time, most of the work has been in Romania. I've interviewed hundreds of people, accompanied doctors on rounds, did years of participant observation, including living in a TB sanatorium. And I didn't originally go to research DOT, but one of the things that I found as I was researching why treatment outcomes were so bad was that DOT was both problematic for the people being treated and for the providers. So that became something that I have looked at. So I didn't always work on TB. I used to work with people who use drugs, and so that has clouded a little bit the way that I look at TB. And I've been thinking about this more and more as I work in person-centered care and things like that. And in drug use, we have a harm reduction approach, which means that the whole purpose is to minimize the negative health, social, and legal impacts associated with drug use for people. This is grounded in human rights. And the idea is that you don't force people to change, you don't judge, you don't coerce. Most importantly, you meet people where they're at, and you do that by caring for them. And the more and more I think about this, I think this is what we need to be bringing to TB. One thing that we know from drug use research is that people rarely are able to stop using drugs or alcohol the first time. What happens is people try and fail and try and try and try until they finally do. And with TB, similarly, I've never met somebody who said, I don't want to be cured. On the contrary, I've met a lot of people who try many, many times and struggle. They struggle because they can't make their lives fit what's required for the treatment. They struggle because of systematic problems, because of economic problems, and sometimes eventually go on to develop drug resistance and die. And this is something I saw over and over again in Romania. It's not for lack of trying. And what's needed is more care and more approaches that meet the needs of the people. It's the opposite of the paternalism and distrust that so much of what we do in TB is based on. So DOT is a really touchy subject, and I'll also say that this presentation is in no way attack on the amazing people who are providing care and really doing their best for people with TB. The first time I presented an early version of this work was about 5 years ago, and it was a video presentation for an MSF Science Day in Ukraine. And because of the time difference, I wasn't able to appear live. And after that happened, I asked one of my friends, hey, how did that go? And they laughed and said, it generated a lot of discussion, and it's probably best that you weren't there, because some people reacted really strongly to questioning the value of DOT and whether it was actually providing better outcomes and things like that. I think we've come a long way since then, and the fact that we had this plenary at NAR a couple months ago, and the fact that more and more articles are coming out and more people are thinking, I think really creatively about how we can do this better, shows that we're moving. A little anecdote I'll give you is in 2013, we had a Green Light Committee review in Romania, and there was a press conference to announce some of the results. And rather spontaneously, the head of the TB program announced that DOT was not happening in rural Romania and that it had not happened for years. It wasn't possible to organize. Well, that was half of the country. And it was something that I had known for a very long time because I had been working in these DOT clinics and watching people coming in from the villages and receiving a large bag of pills with, instructions for when to take them, when to come back. There was no way of providing in-person DOT, and people didn't have the ability to come all the way from a small village in the mountains to the county seat where the treatment was being provided. And when the program manager announced this, one of the reporters stood up and they said, what has happened? Why is this so bad? And at that point, I defended her and I said, no, this is actually really good because we're talking about what's actually happening versus what was happening on paper, but was never really appropriate and never really possible given budgets and public health reach and things like that. But even in instances like that, one of the things we saw was that the people who were providing the care were really caring. And I'm thinking of Nicole's amazing relationship with her provider. And I remember the first time I watched DOT, there was an older nurse there who was having people coming in from the villages. And there was an older man who was all dusty from riding a horse and cart. And when he came in, she opens up her arms to him and she says, "Vine la mama," which means "come to mama" in Romanian. And he comes and lets her hug him. And it was a really caring moment. And you could tell that, she was very invested in his care and providing much more than just medicines. She was providing support as well. So we know that DOT is not happening exactly as it's written on paper. There have been some really good studies on this. The one on the slide is from the MSF site in Mumbai, where there was a very, very different description of DOT that was happening when you asked providers versus when you asked people who were receiving it. There's also been really good data out of China, out of Brazil, showing that it's simply not possible to provide in-person DOT in a lot of these instances. So again, this is not a criticism of the medical personnel who are doing it. People are really doing their best under very difficult circumstances. So one of my main arguments in this talk is that DOT is not in keeping with human rights, and there have been some things published on this recently. I had an article come out about a year ago looking at this, and very recently, Brian Citro and colleagues came out with a really fantastic look at point by point some of the challenges related to DOT. And so there's a growing consensus among the TB community, particularly among social science researchers, human rights experts, and TB survivors, that this one size fits all is not serving everyone. And in fact, if you look at this quote from WHO's ethical guidance for the implementation of the NTB strategy, it explicitly says that DOT is ethically justifiable only when done as a person-centered approach to care. And we know that that's not happening in most places. Oftentimes, what I've documented is bare bones clinic DOT when there is DOT, and then oftentimes self-administered treatment for people who are outside of the reach of public health. Now, those ethical guidelines are currently being revised, and if anybody involved in that revision is listening, I hope that the new guidance will take a strong stand and not just say that DOT is not ethical without other supports, but instead state that DOT is only ethical if it's offered as part of a menu of a rights-based, person-centered approach. It's time to move beyond DOT as being the default and rather provide it as an option if it meets the person's needs. And if it doesn't, then we shouldn't be forcing it on anyone. So thinking about the right to health, these are some of the things that I want folks thinking about as I describe some of the ethnography that I did. Things have to be accessible, and this is one of the challenges. As I described in Romania, the site where medicines were provided was physically inaccessible, being that it was in the county seat in a very rural county, and this was similar in a lot of places. And it was difficult to access in terms of economic terms too, because people were not able to pay the costs to get there. Acceptability, the question that I would ask is the way that DOTs organize acceptable to the people being treated? Does it match their values? Does it match their needs? And then finally, quality. And we've heard already about the mixed and relatively weak evidence supporting the use of DOT, particularly when it comes to facilities-based DOT. So with such a weak evidence base, with these multiple meta-analyses suggesting that DOT doesn't provide a benefit over self-administration, can we say that DOT meets the quality standard in human rights with this lack of evidence? And I would argue that it doesn't. So now I'll describe a few of the people who I interviewed who had challenges with DOT. Mariana, like so many women, caught drug-resistant TB from her father. She was his caregiver and was by his side until he died of drug-resistant TB, and then struggled to get treated herself. And she lived in the city, so she would to an outpatient clinic to receive treatment, but couldn't afford to get there even by public transit. She was very poor, so would walk, and told me that she would rush home because she was afraid that people would see her being dizzy and leaning from side to side from the very strong effects of the medicine and think that she was using alcohol or drugs. She had a child, and when she was undergoing treatment, she was also trying to take care of her son. She was also trying to work. And the way that DOT was arranged really prevented her from doing the basic things that were necessary for her, as we heard earlier, to continue on with her life, because her life absolutely did not stop. She had a very young child to care for. She needed to be able to pay the rent and things like that. Gilda is another woman who unfortunately died of MDR TB and really struggled for a long time with it. She told me how she really felt terrible for her husband because when she was hospitalized, he was all alone with her two children. She said to wash, to cook, to find a job. And he would have to do all of these things, both his own work and the work that she did for their family. And again, they were poor. Neither one had a regular income. What they would do is they would work for other people or sell things at a local market, and really struggled. And the way that DOT was organized where Gilda lived, it was impossible for her to take advantage of. It didn't match the sort of work schedule and unpredictability that her work schedule had. So in this case, DOT was neither physically accessible or economically accessible. She tried and went through over 9 years of treatment with many interruptions before finally dying of DRTB, because the support that she needed was never available to make sure that she would be able to adhere to it. And then finally, two young men, Nikolai and Alexandru, both were in their 20s. Nikolai was highly educated, a really, really smart guy, and both had MDR TB. And Nikolai's struggle was he had a good job, but he wasn't able to maintain it because he needed to go in the middle of the workday to take his medicine. He had MDR-TB, and the way treatment was organized, MDR-TB DOT happened after drug-susceptible DOT happened. So he would have to go in the middle of the day to take these medicines. And he said, you can't say I have to go take my medicine and then come back afterwards. Alexandru had another challenge. He worked in forestry and was actually entitled to 100% of his salary. In Romania, you have this benefit for people who are salaried. But his employer found out that he had TB during the course of his treatment because he had filed this paperwork for the benefit. So we have here problems with privacy as well as non-discrimination, and they refused to hire him back. This is against the law, but something that's quite common around the world. So you have challenges in terms of their right of participation to be able to participate in the workforce, non-discrimination in terms of not being hired, not being rehired, and privacy, in this case, which cost Alexandru his job. So what did people tell me that they wanted? I interviewed a lot of people about how they wish their treatment had been, what they thought, would be possible, would be ideal. And over again, people told me that what they needed was support. The surveillance, they didn't find it to be helpful. And in fact, in Romania, for a lot of the people were not really receiving the surveillance anyway, because it was only possible to do in the urban areas. They needed help with not just transportation reimbursement, but also all of the things that people need. For example, a lot of the folks who were being treated had child and elder care duties. They needed support to keep their homes heated and electric on. They needed guarantees that they would be able to return to their type of work. They wanted social, especially peer support. And we've seen some really great projects. In Romania, they had one where people who had been cured of TB, working with the MDR-TB Patient Association, were doing basically check-in calls to ask people, how are you doing? Are you having any adverse reactions? Is there anything that we can help you with? We see a really great example of peer support with We Are TB and Somos TB in the United States. So we know that this stuff works. We know that we can do it, but oftentimes that type of support is not accessible to people. People ask for psychological support, particularly related to some of the medicines that can have some awful psychological side effects for drug-resistant TB. But most of all, people ask for flexibility, which might include DOT in the community, which might include digital assisted technologies such as VOT. It might mean self-administered treatment with a mechanism to check in with a doctor or nurse about adverse reactions. Some people mentioned the ability for continuity of care, even when traveling between different cities and countries as a migrant for work. So people were really thinking, broadly about this, and these are all great ideas. And in many ways, we don't provide this kind of flexibility across the globe, including in North America. So I think before I get to this slide, I think one of the things that I want to stress is that what I found was that oftentimes DOT was doing more harm than good. It was onerous, and it made it difficult to get through treatment. And sometimes there were these really loving interactions between providers, who were providing good support for people, but the actual having to go somewhere, the actual structure and surveillance, the dose counting was something that people really struggled with. And it also created sometimes, I think, as we heard in Amrita's talk, this opposition between provider and the person being treated, who might feel like they're being distrusted or they're being surveilled rather than being supported. So what I want to ask is, would we create DOT today if we brought together the best and the brightest minds in the world of TB, Is DOT something that we would come up with? And I would change the title and say that no, we would not. This is not a question, because you could not convince me that if you brought together the smartest people who work in TB today, that DOT is treatment observation is something that we would do. We don't do it with other diseases. And even we have a hard time justifying why we do the observation and dose counting within TB. So there's this quote from Karl Marx from the 18th, Brumaire, where he says, "The tradition of all dead generations weighs like a nightmare on the brains of the living." And as an anthropologist, I think a lot about the history of systems and ideas, and how we come to live in the world that we do with the ideas that we have. And DOT is something that in the TB world, we sort of treat as common sense. We do it because we've always done it. In that previous slide, I called it the third rail, meaning the electrified rail in a rail or subway system that you're never supposed to touch. And I receive some pushback when I say, we should really think about how we do DOT and maybe try to move away from that requirement. And I think some of that is fear of losing resources, because if we get rid of DOT, then we might lose the resources that come along with that, like the public health nurses and things like that. But what I would say is, actually, we're not talking about just removing something and not replacing it with anything. All of the folks that are really deeply thinking about DOT, we're thinking about how we can make the system better and how that we can make it really meet the needs of the people who are being treated. And again, that comes from the needs of patients, that comes from being based in human rights, really finding out what are the values and preferences, what do people need to be able to get through a regimen. So as we heard earlier, we're not very good at predicting adherence, but even asking, here are some possible regimens for you. This is the way these drugs are administered. What do you feel would make it easier for you? Do you feel like a shorter regimen or a regimen that might be a little better tolerated but longer would work for you? We should be doing the same things with support. And by this, I mean having conversations about what are the options. So we talk about a menu of options. What are things that we can offer someone to make them feel supported, to make them able to get through this treatment, to enable them to adhere. And these could be economic and social supports. These could be peer support groups. Some people might prefer in-person DOT. And I heard this particularly from some of the older folks that I interviewed who said, that's something that would really be useful for me. And some people might want that in the beginning, but not towards the end. So I think much more so than simply the default and a requirement, we should be thinking about what the menu would look like, what types of support. So there's a crab on the screen here, and this connects to something I've been thinking about. So in my suggested videos on YouTube, these things keep popping up, talking about how independently different species have evolved to have crab-like features, and much in the same, and it makes me think, well, would this happen with DOT? If we were doing this again, if different people came in a room and thought about this, we might come up with all different ways of supporting people, but I don't think that we would come up with systems that look like DOT, because the world has moved on. The way that we think about the needs of people who are being treated has moved on. The way that we think about human rights and people's needs, we've moved past this. So now's the time to really think about what this future could look like. And as I said, it should be differentiated. It should be based in rights. And most importantly, it should be about asking people what they need rather than telling them, and moving away from a one-size-fits-all solution. So thank you so much for your time, and I'm looking forward to the discussion.
Great. Thank you so much, Jonathan. Really for closing our session with such an inspiring focus on the people that we're there to serve and their rights and needs. I'm going to turn the Q&A session over to Jane. I just at the outset I want to thank all our speakers, and we'll do this again at the end. And we'll have a bit of a closing remark at the very end. So go ahead.
Okay. Emerita, one of your early questions was from one of, I'd have to scroll back to see who it was from, but the comment in question was about the differential funding in HIV versus TB cares, and has that led to the differential patient support?
Yeah, absolutely. I mean, you have money, you can do so much. And without doubt, one of the critiques, even in kind of the space of integration of TB and HIV services, was, well, who's going to foot the bill ultimately if you do integrate these programs, and TB had no money to offer essentially. So certainly, like, resource richness is going to play into how much you can do for patients and people with the diseases that we manage. But even in the poorest settings, you will see certain hallmarks of HIV care that are people-centered and that are holistic come through. Because that kind of dogma, I guess, or that philosophy it's entrenched, right? You have to talk nicely to people. You can never call them suspects. You have to explain to them what the HIV test means and does, and you have to explain ARVs before you begin treatment, right? Those things happen with or without resources. That you can't escape them, and they become entrenched in care practices in HIV, even in the poorest of places. So yeah, I think resource richness is a huge piece, but it doesn't explain why we do what we do in TB.
Yeah.
Not entirely.
And don't you think it also makes program managers who have to write budgets a little uncomfortable, because it's sometimes easier to put into a budget an FTE for an outreach worker counting doses or for a DAT that counts doses than some of these other softer, I call them softer things that we may need.
Yeah, but I mean, so there's a lot of task shifting that has happened in HIV, for example, right? Like, well, and there's a lot of so for example, if they were to do, I'm not an economist, but I would imagine that if you were to add up the math of the resources that you spend on, people doing DOT, health workers kind of, opening their computers and checking in on patients as they ingest their medicines or what have you. If you were to add up all the hours that they're spending there and just devote that to a lengthier conversation at the start of treatment, touch points for sure. You want some sort of touch point. The human to human interaction is unmistakably valued across settings. And certainly there's tailoring, right? Some people may not need that and other people might. But I think there would probably, I don't know if anybody's done an economic evaluation of comparing like a, people-centered, meaningful approach given in nuggets and small doses versus this kind of everyday observational piece. But that's a great research question. Thanks, Jane.
Jonathan, I think Nicholas had a question that he put in the chat earlier for you. Assuming a functional DOT system which places minimal burden to the patient, which exists in my jurisdiction, which specific article of the UDHR do you believe is violated by DOT? Article 12. Does Article 29 factor into your argument? I don't know if you know off the top of your head those specific references.
Yeah, I would have to go into the UDHR for that. For my article and for this presentation, I'm using the general comment on the right to health from the International Covenant for Economic, Social, and Cultural Rights. But there are some of the same themes. So one of the issues could be privacy, in terms of people finding out that they're receiving DOT. And we heard Nicole mention this as well, the fact that the public health car in front of the apartment was not a good look for the business. This is also something that we saw in Romania. The Global Fund very generously funded vehicles for all of Romania's 41, I think, counties, but they had emblazoned on the side of them the Global Fund, provided by the Global Fund to fight HIV, TB, malaria, and the National TB Program. So they very clearly showed that there was someone from the tuberculosis program there at your home, or they're checking in on you. So privacy is certainly one of these things, which can go on to non-discrimination as well, in terms of people being able to keep their job, as well as the ability to participate in work. Again, as Nicole had mentioned, the way having to be somewhere at a certain time can get in the way of one's ability to do different kinds of jobs. So I would say that even in well-managed settings, there are still some of these issues where that are problematic.
And we just had there from Jessica Kwan. In our jurisdiction, we do DOT for all our TB patients. Part of our struggle with situations where the patient, especially those on active TB treatment, want to spend time away in the bush, remote areas, for weeks at a time. How do you balance client freedom versus risk of side effects? I'm not sure which of you might like to take on that.
I can try. And I think Amrita mentioned it as well, that the need for these touch points. One of the things that DOT is doing is providing an opportunity to talk with a nurse or doctor about how one is doing. Now, that doesn't have to happen with DOT. That can and should happen in other ways. But I think this is one of the things where, and I had mentioned in my presentation, I feel like the surveillance may even get in the way of that relationship. Rather than dose counting, talking about how are you feeling? Are you experiencing any of these side effects? Are you able to do the things you need to do to care for your family? Those things should absolutely be part of what we're providing, but that's not part of the surveillance. That's another kind of support. Amrita, did you want to add anything?
No, I think you said it beautifully.
And I don't see another specific question as we wind down, but there are many comments that I'd like people to be aware of in the chat. It's very interesting. Some people are putting in what their jurisdiction does to promote patient privacy, such as emblems that go over the notice on the cars that this is from the health department, from other strategies that they actually have. And it's really great to see that so many people have tried to really begin to grapple and address with some of these problems. And several people also mentioned that this is actually Nurses Week. And so wanted to also just put a thank you to all the nurses in the audience who do this type of patient-centered care every day. There's a hand from Mary Green. Can you unmute yourself and ask your question?
I have no question. I just have a couple of things. Thank you so much, Jane, for mentioning Nurses Week. They are the backbone of TB treatment. My point was going to be, we've been very successful here in Florida with video DOT and utilizing the patient's phones themselves to create a store forward. I see Dr. Newton nodding. Yes. I mean, it's been super successful. We've been lucky because we were able to create statewide our own situation. And I know I mentioned before, I think, everything depends on funding and who you get it from and how you get it. But when you come to video DOT, and once a patient is, regarded as being someone who we trust to continue their medication, whether we go ahead and say, oh, let's do a couple of months, let's do this DOT, whatever way, But especially as you're talking about those in the bush or those that are far away, we have that all the time. We also have people that travel internationally, and it's been super successful. We created it here ourselves. So I just would like to brag about that and invite anybody who'd like to give me a call. I'd be happy to share everything, which we've already done with CDC. So thank you.
Thank you, Mary.
So, um,
You, Kevin.
yeah, so once again, I want to thank all our speakers for really an outstanding afternoon or morning, depending on where you're all sitting. Um, uh, I just before we last comments, I just want to make a couple of plugs. So first of all, as Jay mentioned at the outset, the next North America Region annual conference, which is really a venue for this type of an outstanding venue for this type of discussion, will take place in Philadelphia, February 24th to 28th. The other plug is again this plenary was again originally part of that conference, which is the North America region of the International Union Against TB and Lung Disease, or the Union. This is really the premier community of practice and science for all things TB. For those of you who are not members, I would strongly encourage you to join. Particularly for trainees and allied health professionals, the membership rates are really quite cheap. And I'm pasting the link in the chat, which you can click on to get more information. But I would strongly encourage that. You also get free access to the Gray Journal, the International Journal of TB and Lung Disease. And again, it's really a great way to network with other people interested in and passionate about TB. So with that being said, again, thank you to all our outstanding speakers. I think all of us would be happy to receive any feedback individually if you have it. We're interested in continuing this discussion, probably in printed form and in policy form. So again, all feedback is particularly welcome in that regard. And just in closing, I'd also like to thank the UCSF TB Center for supporting this webinar. You guys have worked tirelessly and brilliantly behind the scenes. And thank you to all of you for attending. We've had over 200 people at various times, which is outstanding. And again, we hope that you will continue to see you engaged and active in the TB space in the months to come. And with that, wish you a wonderful rest of your day wherever you're sitting, and much success and happiness in your work. Have a good afternoon.